a proud Buckeye from Ohio. Dr. Bhatt is currently a VIR at Kaiser Permanente. His clinical focus include PID, PAD, PE, and more. And as we know, knowledge of medical management is crucial given the diversity of vascular intervention for the condition that VIR can treat. So today, Dr. Bhatt is here to speak just on that, the role of medical management in vascular intervention.
Thanks for having me today, guys. I'm one of the VIR physicians at Kaiser Sunset with Dr. Vatican Chair, Dr. Consagra, and the three of us and our partner, Dr. Lamb, are really passionate about vascular disease. It's something that I think that we have the opportunity to add tremendous impact in our patients' lives and our overall community. So I'm going to talk a little bit about medically managing this fairly vulnerable patient population, and feel free to jump in and ask questions whenever. I have no disclosures. When we're talking about peripheral arterial disease, we're really talking about a spectrum of disease, right? And you can think of them as sort of three separate entities. It progresses from asymptomatic peripheral disease to intermittent claudication and chronic limb-threatening ischemia. And when we usually are treating patients, we're typically treating patients that are fairly sick, that have extensive disease throughout their body. Particularly chronic limb-threatening ischemia is defined by the presence of rest pain and gangrene and non-healing wounds. But the importance of even recognizing and treating asymptomatic and symptomatic PAD is because you think about the blood vessels as one organ system, head to toe, it's the same thing, right? And when patients have peripheral disease, they have a coronary disease equivalent, right? They have a cerebrovascular disease equivalent. And so mortality many times is related to the presence of stroke and heart attacks. And so even if we're not, if we're seeing patients with PAD and they're not symptomatic, you still have sort of the opportunity to make life prolonging interventions medically. And that's a little bit what I'm going to talk about now. When we talk about mortality in patients with peripheral disease, the more severe your peripheral disease, the poorer your prognosis, okay? If you have gangrene, there's a 1 in 2 chance that you're going to be dead within a year, right? There's a 1 in 5 chance you're going to lose a limb, in a year. So it's quite serious. And in fact, when you compare peripheral disease to other sort of, cancers and really, quite life-limiting disease processes, chronic limb-threatening ischemia has a very high mortality rate that rivals and surpasses a lot of different cancers. Now, why should we be involved in this space? One, because we pioneered the specialty, right? We pioneered endovascular medicine in all fields in medicine. And we already see a lot of these patients, right? Patients with end-stage renal disease, superficial and deep venous disease, older patients with nondescript leg pain, osteoarthritis, or oncology patients. These are all diseases that share commonalities, and whether or not we're involved in treating vascular disease on a regular basis, we see these patients in the office, and it behooves us to do what we can to medically optimize them. And so when we talk about treatment in interventional radiology, for better, for worse, as soon as we start talking about it, this is a famous scene from The Office. This is them talking about kind of, this is us talking about what's best in treating these patients, right? Is it endovascular therapy or bypass? But rarely you hear debates in the interventional space about kind of the medical management. And I would argue that more than this, we should be focused, particularly in our offices, on how to medically sort of optimize these patients. And really it comes down to risk factors, right? So this kind of highlights the different modifiable risk factors in treating peripheral disease, and really comes down to diet, smoking, activity level, sedentary behavior, modifying your lipid profile and your weight, right? And so we're going to talk a little bit about that. So your diet, how do you counsel patients on what to eat other than eat right and do your best, right? It can be challenging. And this is a funny meme I found regarding diet. This is Wayne Rooney on the left, and that's Cristiano Ronaldo on the right. And they're both the same age, believe it or not. This one talks about British cuisine, but you could easily replace that with an American diet. But the Mediterranean diet, what is it, right? It's really just, it's focusing on eating overall less sugar, right? More grains, more whole grains, more fish, more seafood. Meat that's not red meat, and again, trying to minimize how much sugar intake you have, right? Now, the challenge in peripheral disease is that this is often a disease of the vulnerable, right? And there's substantial healthcare disparities. The Mediterranean diet is an expensive diet, but we do know that patients, when they try to adhere to it, have fewer cardiovascular and fewer limb events. Smoking cessation, it's a no-brainer, right? Everyone who smokes should be counseled at every visit to stop smoking, but only about 1/3 of patients who smoke are offered smoking cessation counseling or medications. Again, there's such a low bar, and hearing it from a doctor makes more of an impact than hearing it from a family member or friend, and we know that. The Eagles trial is a fan favorite in our program. We talk about it a lot, using varenicline as an adjunctive medication. It improves outcomes. It improves success rates compared to Wellbutrin or bupropion. And so it's an important tool in our armamentarium. Lipid lowering therapy, right? Talking about cholesterol. What does it do? It really stabilizes plaque progression. And we're really talking about really focusing on LDL levels. And we know if you can reduce LDL, you can reduce major cardiac events, MACE or MALE, right? Major adverse limb events. And there are a number of different emerging therapies, and there are a number of different lipid sort of therapies that are not listed on this list, but the main kind of categories are statin therapy, PCSK9 inhibitors, which are relatively new, and ezetimibe. And of course, your goal, LDL, if you have a patient with peripheral disease or coronary disease, is less than 70. Statin therapy, what's the evidence, right? There's an incredible amount of evidence saying that every patient with peripheral disease should be on a statin. Hundreds of thousands of patients in these registries and trials. And we know that statin therapy does a lot. The pleomorphic effects of statin, plaque stabilizing, it improves walking distance. In fact, if you intervene on a patient, if you do a procedure on a patient, there is some data that statin use is going to improve survival and limb salvage rates following revascularization compared to if you don't use a statin therapy, right? And the tragedy is in patients with peripheral disease, particularly patients that get treated for peripheral disease, only about 1/3 of them are going to be on a statin, right? This is our opportunity to add value. PCSK9 inhibitors are a newer class of agents fighting elevated lipid levels, and they're monoclonal antibodies. You take them it's actually a subcutaneous injection you take every 2 to 4 weeks. The data is based on the Fourier trial and the Odyssey trial. And any metric you could use to evaluate PAD patients improves, right? MI, stroke, mortality, MACE, MALE, major amputation, need for emergent or urgent revascularization. We, really focus on using these drugs on patients that are intolerant of statins or on statins, but have persistently elevated LDL levels. Glucose lowering therapy, right? So there's a pretty clear link between type 1 and type 2 diabetes, and we know that they substantially increase the risk of major adverse cardiac events and limb events, right? And there's a direct link between hyperglycemia and microvascular complications, right? And so we know that if we can control blood sugars, we can prevent microvascular complications. So what's that? That's really nephropathy and retinopathy. But it turns out that the risk or the relationship between uncontrolled diabetes and uncontrolled diabetes and macrovascular complications, heart attacks, strokes, that's a little more mixed. And there's some data that supports intensive glucose controlling therapy to decrease amputation rates, particularly the ACCORD trial. That same trial also showed increased mortality in intensive glucose therapy, glucose controlling therapy, due to increased rates of hypoglycemia and complications from that. The two kind of big class of drugs. And so when I say, glucose lowering therapy, I really mean metformin and insulin, right? They may not prevent amputation or they may not prevent heart attacks like we hope. So the kind of classes of drugs that are particularly beneficial, the SGLT2 inhibitors, and then the GLP agonists. The GLP-1 agonists, of course, are all in the news, right? Semaglutide and tirzepatide and the like. And our goal A1C for all these patients, we counsel them less than 7. It turns out that A1C goals actually should be highly individualized based on comorbidities. There's a real risk of hypoglycemia and perhaps patients that are older with more comorbidities. That goal is not so set in stone, but something to think about. More importantly, any patient that you see in the office with diabetes, when you're counseling them on controlling their blood sugars and doing the, adjusting their diet, those kinds of things, you have to take the opportunity to counsel them on foot care and show them what that means, right? You should also be doing a quick neuropathic exam to check if they have neuropathy, and it's a 2-minute exam. You take a 10-gram monofilament and you're touching these, really 4 to 8 areas on the feet, to see if they have sensation, right? And if they don't have sensation, so they have, what we call loss of protective sensation, it's a great opportunity to give them sort of lifestyle advice, right? So patients with diabetes and neuropathy, you say, hey, make sure you moisturize your feet so you don't develop dry skin and fissures, which turn into ulcers, right? If you have neuropathy, make sure you're not walking around the house barefoot. So I have the opportunity, I take the time to give them that counseling, because again, only about a third of patients who have diabetes receive this regular foot screening. And we see these patients in the office all the time. It may not be for their vascular disease, but it's a 2-minute conversation to have, right? Antithrombotic therapy, right? So aspirin and P2Y12 inhibitors like clopidogrel. We know that aspirin, as secondary prevention, and primary prevention can reduce cardiac events, but there is an increased bleeding risk. For primary prevention, the use of aspirin is a little bit controversial. And there's actually no study that shows benefits of aspirin monotherapy for preventing limb events and amputation. We do put, every patient with symptomatic PAD, so claudication or gangrene, should be on an antiplatelet agent such as aspirin or Plavix. All right. The Capri trial compared aspirin and Plavix or clopidogrel in patients who and compared their cardiac event rates with these 2 medications, and Plavix came out on top. There was not a huge advantage of Plavix there's a slight benefit regarding MACE enhanced in the peripheral population, but no significant advantage with regard to limb events. So that's important to keep in mind. Intensive platelet strategies, right? So we put patients on daclizumab, dual antiplatelet therapy all the time, right? Turns out that simply putting patients on aspirin and clopidogrel probably doesn't have a benefit in preventing limb events. We do it though because it's based on some of the cardiac literature and the trials regarding drug-eluting technology, so drug-coated balloons. But that is something that I think might be a surprise to a lot of people. Recently, you've had a couple trials, the COMPASS trial and the Voyager PAD trial, extolling the virtues of rivaroxaban. So low-dose rivaroxaban is helpful in particularly post-intervention in decreasing the risk of complications regarding particularly acute limb ischemia, amputation, MI, and stroke. So a lot of our patients now, after we do a procedure on them, we'll put them on low-dose Riva in addition to aspirin. Of course, there's also functional therapy, right, when you're managing these patients. And when we talk about patients who, have claudication, how do you help them outside of intervention and diet and lifestyle modification, right? You can prescribe them Platal, right, 100 milligrams twice a day. Most common sort of complications or problems I hear with this medication: diarrhea, upset stomach, sometimes flushing and headaches, right? So you counsel them. I tell them if you have these symptoms, start at 50 milligrams twice a day, and after a few weeks, you can go up to 100 milligrams twice a day, right? There's definitely statistically significant improvement in maximal and pain-free walking distance, but it's not a ton, right? And you have to be mindful of patients with coronary or congestive heart failure, because if they're on another medication, or if they're on nitroglycerin or anything like that, it can cause arrhythmias. It could be a problem. So any patients with an EF of less than 35.
But we're gonna have to kind of wrap it up soon for the next speaker.
Got it. All right, we're almost done here. The long and short of it, when we're talking about prevention, right, with peripheral disease, patients don't really know what peripheral disease is. Primary care doctors, even though they know what it is, perhaps aren't aware that their patients have it. Only about a third of patients get appropriate counseling and screening. And I know it can be a lot, particularly because in residency, we don't, get trained to focus on the medical management of treating this disease. But I do think that, you start where you are and do what you can, and go from there. You don't have to hit a home run and be a perfect clinician. It's lifelong learning and practice. So anyways, that's happy to answer questions.